Hi, I'm Gary Whitman. I'm a professor of radiology and radiation oncology at MD Anderson Cancer Center in Houston, Texas. Today we're going to talk about staging the breast and the regional lymph nodes with ultrasound. Thank you. The objectives today are to understand the role of ultrasound in staging breast cancer, also to appreciate the role of ultrasound in evaluating the regional lymph node basins, and in addition, we want to appreciate the role of ultrasound-guided biopsy in staging breast malignancies. In our talk, we're going to focus on tumor size, involvement of the skin, and also involvement of the pectoralis fascia, the pectoralis muscle, and the chest wall structures. In the second half of the talk, we're going to focus on looking at the regional lymphatics and how regional lymph node involvement can be detected by sonography. When we think of staging, we really want to think about the breast as well as the regional lymph nodes. In addition, an important part of staging is to look at distant sites, such as involvement of the liver or the lung, but we're not going to focus on that in today's talk. On today's talk, we're going to talk about the breast, looking for how many lesions are present. Is there evidence of unifocal disease, disease with more than one lesion in the same quadrant, which we call multifocal disease, or multicentric disease, where there's more than one quadrant involved. In addition, we're going to talk about the regional lymph nodes and how ultrasound can help us in identifying regional lymph node involvement. So for example, here, if we look at this lymph node, this is an axillary lymph node, we can see that the hilum is markedly compressed and there's an enlarged cortex here. This lymph node was a metastatic lymph node. We biopsied the enlarged cortex here to show that this patient had involvement of this metastatic axillary lymph node. When we're looking at breast tumors or breast malignancies, we really want to determine how many lesions are present. We want to try to determine if there's evidence of multifocal disease with more than one lesion in the same quadrant, or if there is evidence of multicentric disease with more than one quadrant involved. So for example, if we look at this lesion, this is a hypoechoic, ill-defined mass. This is an obvious cancer. This was a large invasive ductal carcinoma. But we're also going to look in other parts of the breast to see if there are other lesions involved. And notice how in the same quadrant we see two additional lesions. So this is an example of multifocal disease. What we would do in this case would be to biopsy the large lesion. For example, we do a core biopsy here. And then you could biopsy the lesion that's furthest away, such as this one. If we had good cytology support, we could do a fine needle aspiration. If not, we would do a core biopsy of this lesion and then place clips in both this lesion as well as the main mass. Now, regarding biopsy of the second lesion or the satellite lesion, FNA is a good option if you have good cytology support. If you don't have good cytology support, then you should proceed with core biopsy. When we think of staging, we're going to refer to the TNM system published by the American Joint Committee on Cancer. And the T stands for tumor, N for nodes, and M for metastatic disease. When we think of the T, the tumor size, fairly straightforward, that we're giving a T value based on the size. For example, less than 2 cm is T1, greater than 5 cm is T3. And note that T4 is any size with direct extension to the skin or the chest wall. This is an area where we can identify T4 disease, especially involving the skin, on ultrasound. Then when we consider classifying the nodes, we take the nodal station as well as the number of lymph nodes involved. For example, N2 would be metastatic disease to ipsilateral axillary lymph nodes. N1 is metastatic disease to movable axillary lymph nodes. When we think about N3 disease, one area where we can make an impact with ultrasound is looking in the infraclavicular as well as the supraclavicular region. In both of those areas, if we find involved lymph nodes, metastatic lymph nodes, the patient would be classified as N3. Here's an example of an involved internal mammary lymph node. Notice the lymph node here, somewhat expanded, oval but irregular, heterogeneous echotexture here. This is evidence of metastatic disease involving an internal mammary lymph node. Here's an example of involvement of an infraclavicular lymph node. We can see that this lymph node, we have very little remaining hilum, a little bit of hilum here. The borders of the lymph node are irregular, as you can see here. On this side, we're going to do the biopsy of this lymph node. Here's our biopsy needle in the node, and we're doing the FNA. So notice our needle coming through the pectoralis muscle here. So if we're doing this biopsy, we want to give quite a lot of local anesthesia here. And then we biopsied this lymph node. This was positive, so this was evidence of N3 disease with involvement of an infraclavicular lymph node. Here's another example of N3 disease. These are multiple matted supraclavicular lymph nodes. We see multiple lymph nodes that are matted together, and this is an example of N3 disease. Here's the same case with power Doppler showing that there is a little bit of flow at the periphery of some of these lymph nodes. Another case showing several matted supraclavicular lymph nodes, some of these rather large, like this lymph node, again an example of N3 disease. When we think of metastatic disease, MO or M0 is for no distant metastases, and M1 is evidence of distant metastatic disease. That would be involvement of a distant structure such as the lung, the liver, etc. When we compute our staging, then we take the T, the N, and the M. For example, if we were going to look at 2B, these would be the characteristics of a 2B lesion. It could either be T2N1 or T3N0. Now, when we look, for example, at stage 4, that would be any T or N with metastatic disease, for example, involvement of liver, bone, or lung. But note the importance of N3. This is in 3C disease, that's any T with N3 disease. So here a good example of N3, as we talked about, would be involvement of the infraclavicular or the supraclavicular lymph nodes. And note how if there's T4 disease, that makes this patient to be staged at stage 3B. So what is the eligibility for breast conservation? Well, we don't want to have any skin edema. We don't want the surgeon to cut through diseased skin. In general, we want the tumor size or the extent of disease to be less than 5 cm, but this is somewhat variable. We could go more than 5 cm, for example, in a very large lady, but it may be 5 cm may not be amenable for breast conservation in a rather petite woman. In general, we want no multicentric disease for the patient to be eligible for breast conservation therapy. Now let's see how many lesions we can find and how ultrasound can help us. Here's an example on this. Here's the main lesion right here. Here's a second lesion, a satellite. Here's an intramammary lymph node, and we know that if there's intramammary lymph node involvement, that in general the patients have a worse prognosis compared to those without intramammary lymph node involvement. And notice at the edge of the film, there's axillary lymph node involvement here. So this is the second lesion, or the satellite lesion. Coming back to it is here. This is satellite lesion. Here's our axillary lymph node, and notice how the hilum is markedly displaced and a greatly expanded cortex here. And this would be the axillary lymph node involvement here. And then we looked in the infraclavicular region, and we see these lymph nodes here. These are hypoechoic, no visible hilum, infraclavicular disease. This would make it N3. So when we're documenting evidence of multifocal disease, what we want to do is sample the main lesion and the lesion farthest from the index lesion. Again, we would be able to use FNA to sample the satellite if we had good cytology support. I'm quite fortunate at MD Anderson that I have very good cytology support. If that was not available, then I would do core biopsy, and then I would clip the lesions after showing that there was evidence of metastatic disease. Here would be an example of multifocal disease, and the patient has been going for breast conservation. This is sliced specimen radiography. We took the specimen and then we sliced it like a salami. So here's one lesion with the localization wire, and here's our second lesion with our clip marker. Here's the wire, and notice how on the sliced specimen radiography this lesion is close to the margin here. So let's take this case. This is a hypoechoic mass, irregular. This is an obvious cancer here, invasive ductal carcinoma. And then we want to look in the neighborhood to find the satellite. So if no other satellites were identified, we would measure this distance, biopsy this one, presumably with core biopsy. This one we would biopsy with FNA if we had good cytology support, or with core biopsy. And then we'd place a clip in both lesions to document evidence of multifocal disease. So let's take a case here. This is a palpable mass in a dense breast. So we want to ask ourselves, where is the mass? How many masses are present, and is the patient a candidate for breast conservation? So here we're looking in the retroareolar region. This triangular marker indicates evidence of a palpable abnormality. This is the nipple marker. The nipple is somewhat inverted in this case, and here's a mass in the retroareolar region, irregular mass here on this mammogram. The question is, how many masses are present? So on sonography, we have the main mass, we have a second mass, and then we have a third mass. But it's very important to keep on looking. So here is number 3. There's actually a fourth one here. So we want to biopsy this one. In this case, I did a core biopsy here, and then I did an FNA on number 4 and placed clips at both. And then we documented that there was evidence of multifocal invasive lobular carcinoma. Let's take another case to show the role of staging. In this case, this is a obvious cancer, an irregular spiculated mass. I don't see any additional satellites on this mammogram. Here we have our ultrasound, the main mass, hypoechoic with marked shadowing. And then we did sonographic staging. We found another lesion, a satellite here. Note, here's the main mass, and we're measuring the distance from the satellite to the second to the main mass. When we go back to our mammogram, I really don't see any additional lesions. We put a clip in both lesions, in the satellite lesion, and you can see here there is a satellite lesion that we did not identify on mammography in this patient with a rather fatty breast. Then we gave preoperative chemotherapy. Notice how the main tumor shrinks down. There still is marked shadowing, and the satellite lesion has decreased in size significantly. Here's the clip marker with a comet tail artifact right here. This is showing the clip marker, and this is showing the main mass, both decreased in size in a patient undergoing neoadjuvant chemotherapy. When we're thinking of looking at the extent of disease, we want to look at prominence of the ducts. This is somewhat similar to suspicious microcalcifications in the duct system extending toward the nipple. So in this particular case, notice how this is a regular mass. Notice how there's ductal extension here. And if we look here, there's extension of the ducts really going in both directions here. And sometimes this can be quite long, as we see here. The main significance is that we don't want the surgeon to cut through involved ducts. Sometimes we may localize on either side of the ductal involvement, or sometimes we may even biopsy these areas to prove that there's evidence of involvement. Again, ductal extension, sometimes rather irregular and long, as you see here. This is a little bit different, but these are rounded areas. But notice that they're not purely cystic, some irregularity, some internal echoes. And this was an example of DCIS with microinvasion. And then we biopsied the area. We picked for an area that was hypoechoic with some internal echoes to make the diagnosis. Here's a similar case, calcifications, some with shadowing, marked calcifications. This was an example of DCIS with microinvasion. Somewhat similar case here. When we look very carefully, we see some calcifications. We see some rounded spaces, rather small. There is some flow with power Doppler around some of the rounded spaces. So this is somewhat suspicious. I'm going to try to biopsy the areas of calcifications with my biggest device or with a vacuum-assisted device and take multiple cores and then follow that up with a specimen radiograph. And that's what we did right here, and we came up with a diagnosis of DCIS with microinvasion. We're going to turn our attention to staging the lymph node basins. We're going to focus mainly on the axillary lymph nodes, but a lot of what we say can be applied to the infraclavicular, supraclavicular, and the internal mammary regions. And also the other nodal area that we should think about would be the intramammary lymph nodes, INTRA, because we know that patients with intramammary lymph nodes have a worse prognosis compared to those with no intramammary lymph node involvement. Here's an example of some irregular calcifications in this axillary lymph node. Sometimes we can see calcified lymph nodes in a metastatic in the metastatic setting. Sometimes we have metastatic disease from a non-breast primary, such as ovarian carcinoma with pseumomatous calcifications, and we can sometimes make that diagnosis on mammography. And here we see some involved lymph nodes on MRI. Notice how we visualize the lower part of the axilla, but we're not seeing the upper part of the axilla here on MRI. And notice how on MRI, not only are we sometimes not covering the appropriate area, we probably don't get the upper axilla here, but sometimes some of the lymph nodes can be difficult to identify if there's field inhomogeneity, as in this case. I want to talk a little bit about sentinel lymph node biopsy, and just to indicate that this is where we've given the injection in the breast, that we see three areas of uptake in the axilla. Now, this does not necessarily indicate that these lymph nodes are positive, but rather this is indicating that this is where there's sentinel lymph node uptake, and then the surgeon will take out these three lymph nodes, and then the sample will go for careful histopathologic evaluation. When we think of involvement of a lymph node, we should note that metastatic disease is coming through the afferent lymphatics, coming in this way, and then it will expand the cortex, sometimes pushing on the hilum or displacing the hilum. So our disease should come into the cortex from the periphery of the lymph node. And here's looking at the normal lymph node. We have our hyperechoic hilum and a ribbon-like thin hypoechoic cortex. Here we see the thin cortex around our lymph node here. Again, seeing the thin, normal cortex around the anterior aspect of this lymph node. And sometimes it's very difficult to identify where the lymph node is, just as it blends in so well with the surrounding tissues. Here actually is our lymph node. Here's our lymph node. We see a little bit of the outer cortex here, basically blending in with the normal structures. When we're looking for metastatic lymph nodes, we want to look for absence or deformity of the echogenic hilum, and also look for eccentric cortical hypertrophy. Here would be an example where we have a markedly enlarged cortex, as we see here in the calipers, and the hilum is displaced off to the side. This is a metastatic axillary lymph node. So thus it's useful to look at the short axis rather than the long axis, or perhaps to look at a ratio of the long to short axis. For example, if we look at this lymph node, this is the normal side, this is the abnormal side. And let's take the abnormal side. Notice how there's marked cortical prominence. The hilum is markedly compressed, and there's increase in the short axis dimension here. Here would be an example, just looking at a metastatic lymph node. Notice how the hilum is markedly compressed with expansion of the cortex here. So if we were to biopsy this lymph node, we'd biopsy into the area of the prominent cortex. And here's another example of some malignant lymph nodes. Notice this is an oval hypoechoic lymph node. We don't see the hilum. And as the lymph node moves towards metastatic, it tends to become more rounded, as we see here. The other sign that we can sometimes look for is that the border of the hilum is displaced and sometimes straightened, as we see here. Here would be an example. Notice that the hilum is displaced and straightened. So if we were to biopsy this lymph node, we'd biopsy where the yellow arrow is in the region of the cortex here. Here's another example of some hilar displacement with a little straightening right here, metastatic axillary lymph node. Another example here, we have this area where the cortex is expanded and the hilum is displaced here, metastatic axillary lymph node. So ultrasound really does provide some added value in determining the morphology. We can determine if the lymph node is likely benign or malignant, and also this can help us to guide biopsy. It would be FNA, for example, if you had good cytology support. If that's lacking, then we could biopsy the lymph nodes with core needle biopsy. So for example, in this case, we would really go for the greenish cortical bulge as we see here, and that's where we would do our biopsy. And here's an example, this lobular hypoechoic lymph node here. We're doing our biopsy right here, documenting evidence of metastatic axillary disease. So when we think about palpable breast cancers, about half of them have axillary lymph node involvement. Nodal involvement in general is related to tumor size. There are some limitations. We know that the sensitivity is not as good as we'd like, and there are still some limitations on specificity. Here's an example just showing in a visual way a limitation. Here we have a hypoechoic axillary lymph node. We did the FNA, but there was no evidence of malignancy. This patient also went on to axillary dissection. There was no evidence of malignancy. So occasionally we can have normal lymph nodes with a rather worrisome appearance. In general, when we think of physical examination of the axilla, if there's palpable suspicious lymph nodes, 7 out of 10 of those patients will have metastatic disease. If there's no suspicious lymph nodes identified on clinical examination, about 3 out of 10 of those patients will have metastatic disease. There are limitations if we think about patients who've undergone neoadjuvant or preoperative chemotherapy, then we are somewhat limited in identifying involvement of the lymph nodes on clinical exam and ultrasound, although in this cohort, the residual tumor burden is usually minimal. And in this paper, there were about 55 patients with negative physical examination and ultrasound that had axillary metastases. In general, the tumor burden was rather small, ranging in general between 1 and 3 positive lymph nodes. We know that lymph node sonography is more sensitive than palpation. It can identify suspicious non-palpable lymph nodes, and it can be used to guide biopsy. Here's an example, our expanded cortex, biopsy along this pathway here, showing evidence of involvement, metastatic disease involving this axillary lymph node. And here's just another example, just again pointing out a limitation. Here's our known tumor in the 10 o'clock region. On this axillary lymph node, we see a little bit of a bulge here. We're sampling this bulge. Here's the needle right in the appropriate area. FNA came back as negative. The patient went on to sentinel lymph node biopsy, and there was evidence of micrometastatic disease identified on sentinel lymph node biopsy. So with ultrasound, we can identify macrometastatic disease, but a few tumor cells or micrometastatic disease will be very difficult to identify on sonography. The axillary lymph node status is very important as a prognostic indicator. Axillary lymph node status is associated with relapse-free survival. Also, it is associated with overall survival. And the involvement of the axillary lymph nodes affects local therapy. For example, if there's axillary dissection, and also involvement of systemic therapy. For example, most patients with axillary lymph node involvement will undergo chemotherapy. So what we're looking for is lobular expanded cortex, as we see here. The hilum is markedly displaced over here. Here's just another example. See the hilum being pushed over, markedly expanded cortex here. I mark that with a C. Enlarged cortex, so we're going to sample where the C is in this particular case. And notice on our power Doppler, we have quite a lot of flow, but a little bit less flow where the metastatic lesion is. It really is a space-occupying lesion right here in this expanded cortex. Surgical control of axillary disease is important, and also knowing what's going on in the axilla is important for prognosis, for getting prognostic information. Ultrasound has taken on a role recently in determining if the patient undergoes sentinel lymph node biopsy. For example, if ultrasound is negative, then the patient will undergo sentinel lymph node biopsy. If ultrasound is positive, then the patient will undergo axillary lymph node dissection. Let's take a case here to illustrate some of the points we've been talking about. So this is a patient who presented with screening. On screening, 3 lesions were identified, as we see here. Here's the largest one more posteriorly. And also there was involvement of this there was in a large axillary lymph node, as we see here. So this was by screening evaluation. The patient underwent diagnostic mammography showing that these 3 lesions were real. And then the patient presented for ultrasound. These are all transverse images. So here we see an irregular hypoechoic mass at 6 o'clock, an oval hypoechoic mass also at 6 o'clock, and a somewhat irregular hypoechoic mass at 7 o'clock. So in this particular area, this particular case, I'm going to biopsy the 6 o'clock lesion with core biopsy, and then I'll biopsy the lesion furthest away, which in this case is the 7 o'clock. And here I did FNA as I have good cytology support. Lacking good cytology support, you would go for core biopsy in this particular case. So both of these were biopsied. And then I looked in the axilla. In the axilla, we see markedly expanded cortex. The hilum is displaced off to the side here. And we biopsied the axillary lymph node as well. Here we see our core needle biopsy here. And this is the FNA in the 7 o'clock region, ultrasound-guided FNA. Here's the needle right in the lesion. And also we did FNA, fine needle aspiration, on the axillary lymph node. Here we have our expanded cortex, and here's our needle right in the cortex, ultrasound-guided left axillary FNA. Then we look at the results. We documented multifocal disease. The left breast 6 o'clock lesion, the largest lesion, was a triple negative invasive ductal carcinoma. The 7 o'clock lesion was ductal carcinoma. And in the left axillary region, there was evidence of metastatic adenocarcinoma shown by FNA. And in all of the lesions that we biopsied, we placed clip markers as well. As you can see, the clip markers in the breast lesions here, and then a small clip marker identified in this metastatic axillary lymph node here. So let's take another case. This is a 48-year-old woman. Does she have breast cancer? Where is the cancer? What is the stage? So we'll study the mammogram. It's a dense mammogram. But if we look above the line, we can see that there's more density above the line than below the line. Also, if we look here in the outer part of the breast, there's more density than the inner part of the breast. Furthermore, we know that we probably didn't get as much posterior tissue on the CC view as we'd like, but we're thinking that probably the lesion is upper outer. And note this markedly enlarged axillary lymph node. So with that large lymph node, we're thinking either the patient has breast cancer with axillary metastasis or perhaps lymphoma. So we're going to go primarily try to look in the upper outer aspect of the breast. Here's the upper outer aspect of the left breast, 2 o'clock region, hypoechoic mass with indistinct margins. Here we see it. And notice here on the MRI, here's our mass on our T1 weighted images, and notice how it enhances here. And then we did the core biopsy of the 2 o'clock lesion. Here's our core biopsy, orthogonal image with our biopsy device right in the middle of the lesion. We showed that this was invasive ductal carcinoma. Then we go to the axilla. Notice on the axilla how we talked about how the disease comes in from the outside, from the afferent, as we see it here, extending towards the central region, but marked cortical enlargement, as we see here in this lymph node, left axillary lymph node, which was proven to be positive. Here we see it on MRI, on our T1 weighted images, markedly enlarged, and on our T2 weighted images here. But we kept on looking in the left infracollicular region. We saw this hypoechoic lymph node, very suspicious. We don't see a hilum. We biopsied it again. We would give local as we come through the pec here, give a lot of local. We biopsied this to show that it was involved, and this would be N3 disease. So when we look at this case, this was stage 3A. It was T2 because there was a 2.2 cm invasive ductal carcinoma. And it was N3 as there was axillary and infracollicular lymph node involvement. 8 of 18 axillary lymph nodes were positive, and this left infracollicular lymph node was positive as well, making it N3 disease. So when we have a known or suspected cancer, we want to try to identify how many lesions are present, and is there lymph node involvement? Specifically, is there evidence of involvement of the axillary, infracollicular, supracollicular, internal mammary, or intramammary lymph node regions? And staging can be very helpful at the initial evaluation, as well as prior to surgery, to assess response to neoadjuvant chemotherapy, or sometimes we may do staging after the patient has had a surgical resection to see if there's additional disease remaining within the breast or the regional lymph nodes. Thank you very much.